Dr. Jay Lee, and I am the Chief Medical Officer at Share Ourselves Community Health Center in Orange County, California. We have roughly 200 employees. We've got about 16,000 patients for whom we actively manage, 4 sites, plus a mobile unit. And we do have medical, dental, behavioral health. We have a food pantry. And so kind of a one-stop shop, if you will, from the perspective of a whole person and the care that they might receive. I think for us, just like a lot of other agencies, healthcare agencies during this period of time, it was both a blessing and a curse that we suddenly had available to us, the ability to turn tele on and to be, paid for the work that was being done. And, I think the pre-pandemic world, if anything, it showed us that it was never for lack of ability that we didn't pivot to tele. It just, I think the pandemic really showed that we could move pretty quickly, and the old story that healthcare is a slow-moving industry, frankly, it proved itself wrong, because I bet there's at least 50 stories here of folks who frantically pivoted quickly to meet demand and take care of patients. I know that the focus of this particular session is around staff engagement. And so I wanted to share a little bit of sort of philosophically how we approach leadership and in particular staff engagement here. And I think that's the perspective that I'll bring to the group. I know my other colleagues will be focused on other things, but wanted to put a little bit of context around facilitative leadership and how powerful it can be. I know that during the pandemic, it's a crisis, right? And typically in a crisis, the leadership mentality or the leadership approach is more of a command and control style of leadership. And whereas while that may have been true for the most part, I think the other thing that you didn't want to do necessarily is have a situation where you open the doors to the airplane and you're asking the person whether they're ready to jump out of the plane, and then for them to think about it, because basically we kind of had to ask the question and then push people out of the plane all at the same time. So how do you make that feel better than just the sort of typical leadership down to front line? And I think that really involves coming at it with some level of humility and some level of that you don't have all the answers from a leadership perspective. And so what we did early on was establish I would say a really quick regular cadence of meetings that involved people that were doing the heavy lifting with regards to the pivot to tele. So that involved our technology folks, it involved our nursing leaders and our frontline clinicians. And by convening the meeting, it wasn't my intent to say, we're going to do X and I need you guys to do it by Y, but there was some aspect of that. But really, it was an opportunity for us to all commiserate and to learn from one another about some of the challenges that were going on. So call center was involved as well. And part of the challenge in bringing multiple stakeholders around a table is that it could become a cacophony if you're not managing it properly, or it can just become a big complaint fest. And so we went in with clear set agendas. We did a report out on data, and rather than having people speak to particular things, what we would say was, we'd say, can you guys respond to the data? What are your thoughts? What are things that we're doing well? What are things that we could be doing better? And within a 4-week period at the beginning of the pandemic, we were quickly able to pivot about half of our usual volume over to tele, and again, in pretty quick order, in ways that we didn't really never thought we could do, but I think because of the pandemic, it created some opportunity. A lot of that early business on the tele side was around COVID assessments. And part of the reason why we went there again was we presented it in a very staff-friendly way. And one of the key things that I said early on, and I didn't know if I was going to be called out for BS when I said this at the beginning of the pandemic, was my goal was to have 0 cases of COVID amongst the staff attributable to work. Meaning there's nothing that we would do here at work that would put you at, yes, you would be in risky situations, but we would never, purposely put you in a situation where you were going to be exposed unnecessarily. And so part and parcel with that was this move to tele. The other piece of this was, really working our supply chain to make sure that PPE was available for when those COVID symptomatic patients did need to present for testing. And in short order, I think because of sort of these, I guess, a little bit of the proclamation and a little bit of process, right? Just in terms of ensuring that we had this week over week, literal PDSA, iterative improvements, I think we were able to successfully get moving in this. I think where we are now developmentally is kind of taking this to a 2.0 and rethinking about use case for tele and virtual health. What are the situations where tele and virtual health just did not work? Obviously cases where there was suspected abuse, where someone's having straight up chest pain. These are probably not really good use cases, but behavioral health, excellent use of tele. Skin things are hard unless you've got super HD cameras and dermatoscopes and that sort of thing, and we're not quite at that point. But stable chronic disease and follow-ups regarding that, so long as the patient gets their labs done, would be a really good use case. Hepatitis C treatment, really excellent use case. So we're in the process now of thinking about as we exit the gravitational pull of the pandemic, what does this 2.0 world look like? And again, from a design principle, we are bringing staff and various stakeholders to the table to bring us that information. So we have a pediatrician, we have a clinical pharmacist, and we have our CPSP worker, and they're sort of taking us to that next level with regards to what we could be doing in tele. So I think that about hits my time mark. Kim, tell me if I'm wrong, but I'm happy to pass it on to the next person, and I know that we'll be involved in some level of question and answer here towards the end.
Sure.
If there's any questions in chat, I'm happy to answer any questions.
I don't see any questions in chat right now, but if you do have questions, please feel free to put them into the chat function. We can answer them through chat, or we will answer all of them at the end of each of these presentations. But thank you so much. That's a great overview of the work that you all did starting out. I'm going to go ahead and I guess switch over then and have Ali, the Director of Clinical Informatics from Langley Health Services, present her content. I'm going to share the screen, so just give me one moment to pull that up.
Thank you, Kim. Good afternoon, everyone. My name is Ali Ray, and I am an LPN that is currently serving as the Director of Clinical Informatics at Langley Health Services. So we were all asked to speak upon the topic of staff engagement when it came to adopting the telehealth services within our practice. I'm just going to let Kim go ahead and bring up the PowerPoint, but I'm going to continue to speak on and we'll skip through whatever I go over. So quick history on Langley Health. We serve as an FQHC and a PCMH to 3 of our local counties. They consist of Sumter, Citrus, and Marion. We have served in our primary location here in Sumterville, Florida for over 40 years now. We also provide family practice, pediatric, podiatry, behavioral health, and dental in all of our counties. In 2 of our counties, we provide substance abuse treatment programs as well as radiology services. And then we also have pharmacy and a Quest vendor in our primary location. So when it came down to quickly coming up with the best way to serve our patients. Much like Jay mentioned, we were all trying to figure out how are we going to serve both our staff and our patients safely. So of course, telehealth was the best option. Now, when I say we live in a rural part of Florida, I'm not saying we live in Disney, Florida, we live in the villages, but more like we asked people, do you know where Disney is? Do you know where the village is? We're about an hour, 30 minutes to the side of that. So we had our challenges, much like the folks last week mentioned, of having patients and providers and even our staff that didn't have access to internet at home, or even didn't have the best knowledge with technology. So we had to come up with many of the same workaround processes that everyone spoke of last week, having designated televisit rooms, running test visits, providing direct links through emails, text messages, providing equipment that was needed, and so forth. However, what we found to be one of the toughest parts was just getting that initial buy-in from the staff and the patients. So everyone knows that even good change is still change, and that takes time to adjust to. So we had to empathize with everyone, and we still needed to keep in mind that this is a project that needs to get done quickly, efficiently, and yet we want to do it correctly. So I like to think of telehealth as one of those, kind of like one of those big 1,000-piece puzzles that the world just threw at us back in March of 2020, but they took the top away, so you didn't have anything to go off of. You couldn't really cheat to try to figure out where the pieces went. We just had to sort through it and kind of learn as we went along. So one of the biggest sections to me as the director of clinical informatics was the confidence that our staff held in regards to the service that we were offering to our patients. So much like Jay had mentioned as well, that they had to create these training programs, I went ahead and gained confidence myself in the platform that we held and in the workflows that we were going to put in place. I knew them like the back of my hand, but that was going to do nothing for our staff, because when they would falter, then they would end up running to me for my pieces of the puzzle when theirs didn't fit, right? So we wanted to avoid all of that chaos. We had to kick it into overdrive and really focus in on the education pieces we were able to provide them. So what we did was we set up group education in lunch and learn style. We had to do it safely, of course. So each of our facilities had to hold their own and everyone had to be spaced out. We held Zoom meetings. If we felt like individual staff needed extra care in regards to how this process was going to work, we would set it up to where I could travel safely to those other locations, and we would do one-on-one learning sessions. During those group sessions, we would teach the staff how to get the patients onto the patient portal, how to web enable the patients, how to get them through to the appointment dashboard so they could fill in all those forms and questionnaires that we would normally give in office. We wanted them to be able to do ahead of time. We were able to provide sample emails and text messages to our staff to be able to see from the patient side of things. And then we also allowed our staff to come in and watch test televisits so that they could see the provider side of it as well. So they seen it from the beginning to the end. What does the patient side look like? What does the provider side look like? That way, if you're the staff member that's scheduling the appointment, if you're the staff member that's talking to them about the portal, if you're the clinical staff that's verifying information, you know what every aspect looks like. I also went ahead and created frequently asked question sheets and then scheduling cheat sheets for not only the front staff, but clinical staff assistants, as well as the providers. We made handouts and signs for our lobbies, pushing toward a telehealth world. We did marketing campaigns to get patient buy-in, because as big of a piece as our staff buy-in was, the patient buy-in was just as big and contributed to that purpose. Because if you have a patient in front of you letting you know, I'm not going to be able to connect to this televisit, I don't see the point in it, then that's going to feed into your staff's morale. So we wanted both buy-in. We wanted our staff to be as confident as I was in our service. I am the only EMR specialist for all 9 locations. So anything that I knew, I wanted them to know as well. We did go ahead and sign up for Helo check-in. So we were able to get all of those forms done ahead of time. So our other feed, our other selling point to our staff was not only we're going to educate you as much as we can, but also this is going to be as efficient as possible. So they were really nervous about chart prep, getting all the codes that they needed as an FQHC, getting all the information verified with their patients. This was all brand new. I wanted to be able to look at them and say it's not a problem. So we had to get that into place. We built the questionnaires that they normally would have done in office, and they were able to go into the charts and import all of that data ahead of time. So it really made the chart prep workflow go a lot smoother. And then we also met with the staff and came up with the best workflow of, let's call the patients the day before or the morning of. Let's make sure that they can connect. They know if they're going to connect via the text link, the email link. Are they going to go straight to the Helo website? How are they going to connect to this visit? And let's make sure all this data is verified. So it really had them buying into, okay, it's just like I have the patient here in front of me. And you could really see them enjoying their telehealth days because now they had time to catch up on other things in between these telehealth visits. Our providers, that was a little bit more of a, we had to pull a little bit harder at them to get them to buy in, but we created templates and order sets to help with the documentation. So they had that statement in the HPI, they had their modifiers, they were able to feel confident that their note was being done correctly. So then that started to put all their puzzle pieces together for them. Lastly, that bottom right corner of the puzzle that everyone seems to have difficulty with, which I would describe as one of our luckiest tricks that we were able to pull out for staff engagement, was competition. Because here at Langley, we like to make literally everything a competition. So why would that have changed when it came down to telehealth? We started to create gift prizes for the staff. We wanted to see that they were engaging the patients through our patient portal, since it's using our telehealth platform. We were monitoring their chart prep for the televisits themselves to see who was working efficiently. We created kudos and punch cards for those staff members. We created a post-visit survey campaign that included specific questions that were related towards televisits. And then we would share the comments from the patients to the staff to help boost their morale. So we went from a 2% of our total population of patients utilizing Helo in 2019 to now over 57% of our patients utilize that platform. The staff, you can just look at them and see that they're more motivated to educate patients on the benefits of telehealth and the patient portal in general, with the perks that we were able to provide to them. If we were not able to get that staff buy-in with our telehealth services, I guess the best way I could put it is our puzzle would still be scattered around the floor. That whole telehealth puzzle would just be scattered everywhere. We might have had a couple of loose pieces put together, but our picture as a whole would not have been recognizable. So that's all I have for you guys. And I'm sorry you couldn't see my PowerPoint, but if you guys have any questions regarding staff engagement, I would be more than happy to answer you. I think my time is up.
Thank you, Allie, for that. I'm so sorry we weren't able to get the slides to show, but they are available on the resources page. And Allie also provided some great adoption tips for telehealth visits and some of the guidelines for how they created their televisit templates in their charting system in their EHR. So those will also be available to you all for the resources section.
Yes, ma'am. Thank you, guys.
And Allie, I just wanted to make sure you saw Janine Davis commented in the chat there. And I agree. I love the idea of the staff seeing a mock visit. I think the walkthrough.
That was probably
idea.
one of the best ideas that we had come up with, because you could just see the light bulb go off in the staff's heads that, wow, this is what it looks like. And it just made more sense to them whenever they would speak to the patients. So thank you, guys.
And then her other question was for the staff that was not engaging or utilizing the online platform, what were the primary reasons for that? Were you able to discern that?
So the staff that I've noticed that were not as engaged, their provider actually didn't have as many telehealth visits as others. Now that doesn't give them a reason to not do the patient portals as often, but I would go in and I would see that they were calling the patients. It was in our older generation of nurses, but re-educating them, they've gotten a lot better about that service that we have.
And if I could add a comment there, I think the other thing that I'm hearing repeatedly from staff is perception of available time to be able to engage with the patients, particularly when we're measuring other things like cycle time, and this kind of eats into cycle time. And so, I think we've had to communicate that this is not just about one or two metrics, it's actually looking at the whole experience of the patient. And, I think particularly we've worked on some of the tech pieces to make it kind of one-click access to getting portal sign up and those types of things. And those improvements, I think, have also reduced some of those barriers. I remember being on Epic like 12 years ago, which seems like an eternity ago from an EHR perspective. And it was literally like 6 or 7 steps for a patient to get on and verify and blah, blah, blah. And now it's 1 or 2 clicks. So I think as the technology improves and we reduce the click burden that each of us experiences, it makes it easier, not just from a staff perspective, but also from a patient perspective.
Great. Okay, with that, let me go ahead and share our slides here. Let's see if you're thumbs up, you're seeing them?
We can see him.
Okay, fantastic. Well, on behalf of myself and Dr. Fratkin, who I will let introduce himself further in a moment, we are delighted to be here from Vinca Resolution Care, who joined forces a few months ago and talking about telehealth. Dr. Fratkin is our Chief Medical Officer and was the founder of Resolution Care, who has been working in telehealth for 6-7 years, or early pioneer in this work, back when folks said you can't, telehealth will be exciting in 10 years, but you can't flip a switch and have the country do it overnight. And then, of course, as we've all been discussing, COVID flipped that switch and we've been doing it. My name is Brian Missler. I'm a psychologist by training, and I am the Chief Operations and Chief Clinical Operations and People Officer at Vinca, having come over as the former President and COO of Resolution Care. Michael, let me hand it over to you for a second to add some context and maybe encourage some more participation.
Yes, that's what we're gonna do. I bet, Brian, that I could get 50% of y'all to turn on your video cameras. That means that I'm looking for 36 people to turn on your cameras. This is the magic of the experience. Thank you, Lakita. Thank you, Jane, Russell, Kathy, John, come on, make me a winner. April, hello, Derek, Michael McNeely, come on, turn it on. Let's see, how are we doing? Let me just double check. Brian, you keep count, because if we get 36, you owe me a bottle of tequila.
100.
Okay, so
yeah.
Okay, so yeah, if you don't have a camera, what can we do, But maybe I'll negotiate with Brian for my bottle if I get close. But come on, folks. It's, this is really what we're here to talk about. In the last 18 months, we've all been shoved into this new experience. And I'll tell you a little bit about what our organization has experienced. Can you just flip the next slide, Brian? Just so I have a sense of where I'm going. Excellent. So he told you that I started doing this about 8 years ago, 7 years ago, when I noticed this thing in my pocket and I wondered whether it would help me do what I do. And what I do is different than what Jay and his organization and what Ali does too. What I do is palliative care. And I started this organization based on discovery that actually you can do this work beautifully as a team-based home intervention using the technology that's readily available at everybody's fingertips. And so over the course of this 6-7 years of building the organization, by the time we reached, I think it was March 19th, when in California, the shelter in place was initiated, we had about 45% of all of the work that we were doing by video conference. And internal to the organization, as well as external to the organization, we had people resistant to it for all the reasons that probably many of you can imagine or experience yourself or are currently experiencing. And on March the 20th, not only did we stop going into the office, because I, like Jay, committed to zero transmissions in the workplace, in both directions, my beloved workforce and also the people that trust us to care for them. We made a commitment that there wouldn't be a single COVID infection that changed hands during our watch. So we had the leverage to do what I wanted to do for years, which is to tell my team to get behind using video conference as a means to communicate with people. And overnight, we went from about 43 or 4% use of video conference to 100% telehealth. Now, in the first few months, that included a pretty substantial amount of telephone work, but we leaned on the team to explore and experience a transformation in how they think about the work that they do, and to start learning how to use it, work within this frame to do that work. At first, they complained. They said, how can we care for people who are completing their life and suffering so greatly from serious illness without being able to put our hands around them, without being able to hold their hands, without being able to hand them a Kleenex when they cry. But about 3 months into it, when we realized 30 to 40% greater efficiency by getting people out from behind the windshield, they also had time to manage their crazy children, to adapt to working from home, to adapt to online education for your children. I said that twice just because it was such a big deal in my household. They had more room to do that, and they had more room to actually grow capacity to take care of a whole bunch of other people who needed care. And they stopped complaining after about 3 months, and after about 4 months, we got to where we are now, which is about 95% of all of the clinical encounters, nurses, social workers, chaplains, community health workers, doctors, about 94 or 5% of all of what we're doing by video conferencing. There's still a smattering of telephone work. It's allowed in the state of emergency, but we're not going to stay dependent on telephone. We are working completely virtually. That's allowed us to expand a workforce. We're based in Humboldt County, far northern California, a very rural environment without a ton of highly skilled palliative care workforce. So we have a distributed workforce that's all over the state of California, and a few licensed individuals, California licensed individuals that are working from other parts of the country. When we meet with a person, we have the opportunity to also meet with their family members, either sitting next to them on the couch. We get to meet with their pets quite often. But we also get to do multi-site family meetings, which are so critically important to level setting people's understanding of what they're facing in goals of care conversations, transitions of care, discussions about when and what is hospice, when is the right time to move in that direction. And the buy-in has been mostly organic. Like I said, after about 4 or 5 months, when we shifted to this is what we do, everybody got better ergonomic setups at home. They got lighting from us. We'd give them good equipment as they need it, and they got comfortable with managing their outcomes, having greater productivity, and much, much more control over their work experience. I think that, what else should I say, Brian?
Well, let me underscore that point, because Ali, you spoke to this a little bit, and this really was the inflection point for us. If there was a single variable that we could kind of track that predicted the success of the telehealth model, it was the degree to which the individual clinicians, the nurses, the providers, actually bought into it, understood it, felt comfortable with it themselves. And what we saw, like many of us on the call, is that we had a team of people who grew up speaking technology as they learned it later as a second language. And the folks who grew up speaking technology as a first language were naturally kind of more comfortable in that environment. And when they bought into it, then it immediately translated to the people that we cared for. And so as our team developed that competence, you could almost predict the response that we would get from the people, the individuals and families we served, by the buy-in that those staff had. And so buy-in among staff was really a key place. And that came about not only because they learned the technology, but also because we were able to do more. And as we were able to bring more people in the room, they started to see that we shifted kind of paradigmatically from technology as a crisis backup solution to technology as a first solution with all the advantages, right, Michael?
No, that's totally perfect. And what Jay had said, there are certain things you cannot do by video. While there are gizmos and remote patient monitoring stuff that can extend some of the objective assessment with special equipment and various other things, in our work, in the work of palliative care, there's very little that we can't do. We are a co-management structure. We interface and coordinate smoothly and seamlessly with primary care and specialty care practices. So when physical hands-on are required, or a procedure or some objective data collection, we do that in collaboration with other elements of the healthcare system. I'd like to just ask the people who turned on your camera, has your experience of this educational experience shifted a little bit? Now that you know that I can see you and you can see me, see you. It's a different experience with camera on. It really, really is. Otherwise, it's a fairly passive kind of webinar experience. But with camera on, I can see if you're nodding. I can see if I'm getting the responses that I need. There's all this exchange of information that's possible. That's not quite as available on the telephone. And in truth, one of the advantages, so as I said, there's things you can't do. There's things that you can do inside this framework that are extraordinary, probably more than we can talk about in this framework. I'm happy to come talk again. But being able to give people all of the space they need to be in their life and identified as the person that they are and the life that they're living is very different than when you drag their seriously ill carcass into a car and down the street and 2 hours to the clinic in our rural environment, and then wait in the waiting room with the 10-year-old People magazines and all of the other sick people in there. That context has a lot to do with what's possible in terms of getting the intimacy, the connection, the trust, the relaxation and calm that facilitates the exchange of important, actionable information. So there's some real advantages to doing this that you just can't experience when you are working in a brick and mortar clinic environment, hospital room, or even when you knock on the door and invade their home.
Yeah, if I may respond to a couple of points that Dr. Frecken had made earlier. And full disclosure, one of my first jobs in the mid-90s in healthcare was working for a subsidiary of Cedars-Sinai in Los Angeles. And one of the projects I worked on called Zinc Health. And one of the projects that I worked on was a bunch of child psychiatrists from 90210 were tired of going up to Central California or flying or driving up there. And they figured, could we use the T1 lines and some of these camera technologies to actually do our work? And what they found, applying the FDA standard, they found that the work that they were doing virtually was actually non-inferior to the face-to-face, and there were significant cost savings, right? So there's definitely a business case to be made. And I completely agree. I think that particularly with camera on, especially if there's an established relationship with the patient, there's a way to extend that relationship without requiring the face-to-face physical presence, albeit it is always nice to be able to hold someone's hand, and for better or for worse, there's no CPT code for that. But you know, the critical thing is that I think the technology can certainly enhance the relationship. The other point I wanted to, or the other thing that got me thinking was the comment that you made about the staff and their ability to be able to do this from home. And one of the things that we experienced is that the digital divide doesn't apply only to our patients, but it also applies to a lot of our hourly employees who are on the lower end of the pay spectrum. And so we had to be very intentional about essentially creating digital kits wherein you know, you have a MiFi, you've got dual screens, you got a camera, and it was a call out because you know, some of our computers, frankly, were still running. I'm kidding, but you know, still running Windows 95 essentially. So, you know, just a situation where we had to do a reassessment on technology and say, okay, we're going to have to invest some dollars here to ensure that we're able to do it. And some people just weren't able to work from home, period, because either it was a technology issue or it was a HIPAA problem, meaning they had dependents at home. There wasn't any way to create privacy. And so the other piece that we're thinking about very intentionally is, could we create some brick and mortar space wherein we do have virtual teams that are essentially co-located and potentially for those that are particularly talented and have shown an acumen for doing the tele piece, could we convert them actually to 100% tele? And then they could do things like new patient intakes. You know, they could do same-day visits, right? It could be a potential gold mine. It could be a landmine too, but a potential gold mine in terms of access, right? Because we're always struggling with access because we have so many rooms that we can use. But is there a way for us to leverage this and leverage the strength of the talent of our teams such that it could provide a new sort of growth pathway from a career perspective? So thank you. And those things were definitely triggered by your comments. Thank you.
Michael, I wanted to, I see we have one hand up, but I also wanted to ask you about the multi-site family meetings.
Yeah.
Did you use your usual VTC technology that you use for visits, and you're able to include family members? Can you just talk a little bit about the technology and the connectivity there?
Yeah, we use this. This is a family meeting, essentially. It's just got more than you can probably handle for nuanced and deep, very personal information. But I've run family meetings with as many as 15 different people from multiple different parts of the country on a Zoom platform. And so we put a little bit of muscle behind the coordination function. And we've got some amazing care coordinators that know how to help people get up and running on the technology, test it, and get it all teed up so that when the clinician drops into the room, everybody's there. And the goal is that within as many minutes as necessary to get the technology angst to dissipate, the technology itself disappears and the communication unfolds, because that's really the point. It's not about telemedicine. I mean, in the slides that Brian prepared, he didn't talk about palliative care. And out there in the world, I don't talk about telemedicine. I talk only about palliative care because that's what's going on here. And it's medium independent. Whether we're in the room, whether we're at the hospital, whether we're at a coffee shop, or whether we're doing it through this kind of a medium, the stuff of it is seeing people as people and responding to their needs, exploring their needs, and with the hope that they feel seen and heard and understood and empowered to have something to say about the kind of healthcare that they want to receive and the crappy situation they find themselves in. Kuldeep.
Thank you. Thank you for a wonderful presentation. I was a CEO of an FQHC for almost 18 years. And in our area, there is one physician slash PA slash FNP for 2,700 people. So we're heavily health professional shortage area. So I and my team, we started a telemedicine program somewhere around 2001. We had 4 ISDN lines, and somewhere around 2006, when cloud computing happened, things changed. And as you guys are mentioning, I mean, it was deja vu for me, some of the things that you're discussing right now. For example, we have had a very robust telepsychiatry program. And as you say, face-to-face encounters were done in a synchronous fashion, where we had live interaction between the patient and the psychiatrist. And as you said, they would even try to do CBD and interactive. So what the challenge became reimbursement for us. So in that situation, we would get initial patient visit for 45 minutes, follow-ups for 30 minutes, and then medical management was done. So in that fashion, we were very successful only in psychiatry to do live interactive. Mm-hmm. Some people even did store and forward business, like you would take the patient medical history, patient treatment failures, patients from their whatever interventions they have had, and upload it to a specialist. For example, our teledermatology program was very robust, but the problem was nobody would pay for it. And then in state of California.
Yeah, I mean, those are such critical issues. I mean, the economics of how we've made this work is a whole nother topic, but as it relates to the engagement of staff, what I can tell you about a palliative care team, and I hope it's true about a primary care intervention like the other two speakers have spoken about, what makes them engaged and bought in is that it really delivers the professional experience of making a difference for the kinds of people we direct our attention to. If they feel like people who are facing the end of their life or a challenge to their survival are being heard and seen and driving their own care with excellent symptom control, well-defined goals of care and advanced care planning, my team is bought in. That's what they need to experience. If they get an improved freedom to experience their work life in a much more flexible and adaptive fashion so that they can feel balanced in their life, all the better. That helps them with engagement as well.
So talking about quality of care, like for example, my own physicians wouldn't buy into it for a long time. And then suddenly we saw one pemphigus patient, and then we saw patients who have had treatment failures and landed up on the ER many times, but a dermatologist cured them. And suddenly the buy-in became better when the patient felt good. A patient that would travel from 300 miles to come to be seen because their appointment was not available for another year, and we fixed them in 36 hours to 1 week. That was a great buy-in for the staff. And then the younger, again, I don't want to say this, I myself am up in age, but the younger generation want their x-rays on their Game Boy. The younger physicians, the younger staff is much more adaptable to this kind of technology. We did not have, our people are poor, they didn't have cell phones and their numbers would be disconnected. But everybody at that time had a Facebook account. We would get their Facebook account and managing their HIPAA, we would, our prenatal care kid, they were all teen mothers. We would just send in a message on the day of the appointment. Our clinic is here to help you. Just that increased the compliance of show rate amongst the teenagers because they had a consistent Facebook. The generation is shifting. The staff is shifting. The younger staff is much more adaptable and wants to do this.
Yeah, very good. Yeah, no, that's super, super good. I'm glad that it was Facebook that went down yesterday and not Zoom. That would have been problematic for our practice.
Yes.
Well, I think that Brian has been very kind to me because he just faxed me over this, even though he didn't quite get to 50%. He sent it by fax.
Isn't that
That's
incredible?
amazing
This
technology.
yeah.
Technology
That's
is amazing.
You didn't 3D print that?
Yeah,
Our institute has moved particles, so bear is easy.
yeah, really great comment about sort of the patient experience of this. You know, I think sadly there are some business school case studies of cycle time focused in ambulatory settings and how terrible that can be as an experience. And you know, certainly when patients realize they don't have to wait nearly as long or deal with traffic or deal with a bus or three, and can really be seen in the comfort of their home. I think it's a big sell for the patient. I would say even for the staff, you know, the 15-minute visit, quote unquote, right? If it takes 10 minutes to room a patient, which is pretty darn efficient if someone can do that first part of the visit in 10 minutes. And then you think of the third part of the visit, which is the discharge, as being another 10, 15 minutes. Really, you're not, you know, on average, when I've measured how much time a physician's in a room, it's probably about 17 to 18 minutes on average. When you've got a 15-minute visit that is broken up into three pieces and you're not able to, you don't even have that amount of time, no wonder doctors are always behind because we're not budgeting correctly from a time perspective, right? And so what I'm finding with some of the televisits is that our cycle times are actually significantly shorter because the check-in process is much easier. You know, granted, we're not doing vitals, we're not doing the same sort of level of things that we're supposed to be doing, you know, that would be applicable to a face-to-face visit. But the amount of time that you spend in the room with the patient is actually at least 20 to 30% higher because you're not feeling that rush, especially if you're doing a tele all day. So I think the cycle time comments are spot on.
Well, and then the efficiency, when you apply that to a home-based program where there's all the drive time involved, you can see how much we gained by bringing everybody home and keeping them safe and really learning how to solve this problem. I wanted to just throw one thing out because we do have about 75% of our population are Medicaid managed care. The digital divide is real. And so we've solved that by spending money. And we have a stack, I think, of about 80 or 85 data enabled tablets that we lend to people. They don't often disappear. They occasionally get flushed down the toilet, but we use those devices with connectivity built into them as a mechanism to provide very valuable interventions to help them coordinate their healthcare services. So it's an investment that we make. We have had to put parental controls on those devices, though.
I like the comment about the radiology on the Game Boy. It's gonna percolate in my head for the rest of the day.
I have other stories too.
Good. Go ahead, Kuldeep.
Have anyone of you ever thought of creating a special team of telemedicine coordinators? So when we used to do my goal was to do 32 patients a day for derm because we used to get patients from all over the place. So the people who took pictures and the people who did the visits were divided, the roles and responsibilities were divided in such a fashion that we were able to do initial visits, follow-up visits, and do the labs and the diagnostics in such a fashion so that 4 people can coordinate 32 patients for derm. Similarly,
we have exactly that, Kuldeep. We have a great group of care coordinators that make it possible to see these folks efficiently and to let the clinicians and licensed personnel do the thing that they want to do, which is the thing itself, which is to serve sick folks. So yeah, the coordinators are critically important, and they all have found themselves advancing professionally inside the organization, and that's an enjoyment for me. I wanted to ask, is there anybody out there who got surprised by an experience that they had doing their earliest telemedicine encounters over the course of this pandemic or beyond? Is there anybody that can tell me like a story of how they were surprised at how effectively it worked or how terrible it was to do what it was that they were trying to do. Is there anybody else?
Like this.
Hi, this is Katie. I'm a nurse practitioner and a clinical informaticist at Lowell Community Health Center.
Okay.
So one of my recent, I'm sorry, I have a puppy and a child in the room with me, so if there's background noise, I apologize. One of my recent visits was, there's another friend. I'm lucky enough to be in pediatrics, and I had an appointment with a 16-year-old, and I video dialed the patient, and the patient was home by herself and mom was at work. And, you know, we needed to make sure mom was part of the conversation at some point too. And of course, this was, you know, an adolescent who, like we've talked about, grew up with technology. And she was like, oh, that's okay, I'll just add my mom to the call. And of course, exactly. So she, you know, very intuitively navigated our app, which we have found to be very user-friendly, but, you know, more so with younger populations. And it was just such a great visit. Mom didn't have to take time off work. The teen was, you know, in the middle of doing her homework and just paused for, you know, 15, 20 minutes. And we took care of the problem and addressed their needs. And it was just a really nice reminder of how the technology can be so accessible to patients, you know, when it's navigatable.
Mm-hmm.
Right.
Yeah, and when they have something to compare it to, like a problem like that, and what it means to take off work, to grab the kid, to drag themselves to the clinic so that we can process them through as an input for that mechanical process. They've got that, but actually after a while, they start to forget the prior status quo. And what happens is we just drop into becoming the appropriate sliver of their life while they're living their life. Like in a palliative care framework, that's actually very important to not interfere with the experience that belongs to them. And so they sort of take for granted that they click on the thing and there's their doctor, their nurse, their social worker, their chaplain. They have an encounter and then they return to their life quite, you know, seamlessly. And then we get to work behind the scenes in all the actionable elements that we know that will deliver them value because they told us what would make them feel better and have a better quality of life.
So I see another question in the chat channel. I just want to make sure we touch on this really important area before we wrap up. Somebody asked, how do you articulate the value of savings to show return on investment? So as the healthcare administrator, I'll say something about our experience at Vinca Resolution Care, but then I'm very interested, Jay and Ali and others, to hear from you. One is, I think that this issue that we've been talking about specialization of duties, and the more we're able, with the virtual team, we're able to bring in even more members of a team together, and in doing that, allow people to practice at the higher end of their license, and so that naturally creates a certain efficiency. And then the second is what we've also been talking about in terms of windshield time, and it doesn't take a sophisticated accountant to do the math that if you're spending 2/3 of your time in a car in a rural area driving to see a patient, there's going to be some cost savings. And when you're working in a clinic environment, the math is a little different, but they're all kinds of overhead things that you don't need to use. And so I actually think that the ROI is one of the easiest pieces of this puzzle. You can reach out to us if you want to understand more of that. Jay, Ali, is there more that you want to share on that point? And then Kim, I know you'll take us out in a few minutes. We're starting to hit near the end of the hour.
Yeah, I do have some thoughts on that. And I think with the pandemic as the background, the way we sold this was, well, these are visits that we won't have anyway. So, you know, we'll lose them if we don't move to tele, right? We'll lose out on that opportunity. So let's at least get
any number plus zero is better than zero.
Right. So let's at least get some volume, and it's really meaningful for the patients, because when we did some of our outreach, you know, and they're hearing their doctor, you know, or their nurse, and you know, hey, we just want to, we know that we're in the middle of a lockdown, want to make sure that you're doing okay. Wanted to check in with you. Do you need to schedule an appointment? We did some of that outreach, and I think it really helped enhance the relationship piece. So definitely it sort of backfilled any volume that we would have lost otherwise. I think that's sort of immediate ROI. And then the other piece that I'll say about this, and I think you guys were alluding to this, is the work that gets done in the interstitial space between visits, right? And the movement to value-based care, where the APM or alternative payment models for FQHCs is coming. And all that interstitial work that we do between visits with the other members of the team are going to be critical for us to keep patients out of the hospital or keep patients out of the ER, because we know that comprehensive continuous care, that Barbara Starfield touted for the entirety of her career, is value-based care. And that's where we want to go. And I think virtual allows us to do that by bringing in these other team members to make the overall experience seamless and more meaningful from a whole person care perspective.
Okay.
So we are going to wrap up. I want to give Allie a chance to jump in on this if she's got anything to add.
I was just going to say that I 100% agree with Jay. I see the same on our end at being an FQHC. You either have zero or you have that volume from the telehealth. Where we did have our downfall was obviously dental. We couldn't figure out that aspect. I wish we could have, but just that relationship that you end up building with all of the staff during this time and all of your patients during this time, that's investment enough right there.
Well, thank you all so much for being here. One thing do we have any of our friends from Lifelong on the call? They presented last week and talked about the role of the video care coordinator, the person who helps with the technology, scheduling, and then getting patients hooked up with it. And we asked them during that planning session about how they advertised it, what the job description looked like, and how they interviewed folks for that position. And they said that one thing they asked the people who were interviewing to do was to describe a process without using with only using words. So like you would do it over the phone, have them explain how to make a peanut butter and jelly sandwich. And you're telling someone how to do it. So you're saying, okay, go to your cupboard, open it up. You're looking for the peanut butter. The peanut butter should be in a jar, cylindrical jar. It looks like this. And what that allowed them to do is to see how well people were able to patiently articulate to someone who might not be familiar with technology, how to do something that they didn't have a screen up to see or didn't have the familiarity with their phone to do. So that's just one of I was like, oh, I wonder if anybody else, thought about that hiring process and what you would need to be able to do to troubleshoot technology and also to help with the, medical part of it with the actual visit. So I just wanted to share that. I thought it was great. Hi.
Hi, I'm from Lifelong. I'm on the call.
Hi. Oh yeah, you're the one that told me this. Please go on.
What was your question?
I was just talking about how you're hiring. The question that you asked of the folks who were interviewing for the VCR role, and how you asked them to or have someone do a process using only words and not able to see what the patient or the person on the other end had access to.
Yeah, I mean, I think I had been covering for what was later to become the virtual care representative. And what I found was when you're talking to someone who barely uses the phone or is very new to smartphones or apps or whatever, you have to be very descriptive in saying, okay, look for the big blue button on the top left of your screen, press it down. Like at one point I spent like 45 minutes showing someone how to move a cursor around so they could like fill in the form. And so that became one of our main priorities, is having a person who was able to very clearly describe something that they could not see in front of them. And I think that that was a very helpful skill in finding the virtual care rep that we have, because our patient population is kind of, you know, it's very diverse, especially in age and technology access. So having someone be able to be very clear about those kinds of things helped move the process along.
Thanks so much for adding that. We've been talking about engaging with staff in bringing telehealth to reality where it might not have existed in our clinical practice beforehand. And thank everyone for being here. Thank you all for joining us last week and this week. We have another session 1 week from today at 3 p.m. Eastern time. And hopefully those calendar invites that come from our learning management system have the correct time for your time zone, but it is 3 p.m. Eastern, and I'll make sure it says that in the email going forward so that we don't miss any folks who are joining us from the left coast and points in between. Thank you all for being here. Thank you so much to our presenters, and we look forward to seeing you again next week. Bye, y'all.
Hi, thank you, Kim.
Thank you.